Okay, so now we're on to pharmacology, and specifically the agents you're going to choose to achieve this procedural sedation. So this is a pretty significant and often really stressful part of the learning and establishing your expertise and refining sedation for our patients in the choice and the dose of the sedative agent that you're going to use. And when you speak to colleagues about which sedative agent and which strategy they'd use, you often get a multitude of different answers as the best approach for the patient. Now, what that probably means is that there isn't necessarily a best answer for how to sedate a patient, but a variety of different ways that it can be achieved safely, considering the right factors when you're approaching your individual patient. Okay, so going back to the start then. So as we mentioned earlier, when we get to the point of deciding that sedation is appropriate after, again, having considered what needs to be achieved, patient-related factors such as premorbid status, and selecting the right patient, as Rob has just talked us through, having a think about their physiology, so any challenges that physiology presents, having considered the ladder of techniques such as reassurance, analgesia, patient positioning, local anesthesia techniques, etc. But let's say, as we've got to this stage in the day, let's say that we're now at the point we've decided that the patient in front of us actually needs sedation. There is a skill into picking the correct agent for you and that situation and the right dose. So we need to remember that all of these sedative agents are capable of delivering an anaesthetic. And that in itself is a really powerful thing to remember, because giving a patient an anaesthetic is not without a risk. But you could argue that actually delivering sedation is even more of a skill, in that we're really playing in that area between fully conscious and an anaesthetic, and trying to exist in that grey zone whilst delivering procedural sedation, but getting them back to a level of safety and full consciousness as quickly as we possibly can. So when it comes to the specific of which agent and dose we're going to use, we're going to want to think about some key bits about the patient. So first up, things like patient physiology. So certain drugs will make the likelihood of things like hypotension greater. And in certain patients, that may bring about significant risks, especially when you consider the reason for which they're being sedated. Let's also have a little think about the procedure. So what about the duration that you need them to be sedated for? Now again, different agents will last for different amounts of time. Some lasting for a couple of minutes and others lasting for a much longer duration. So we could be looking at cardioverting somebody, which essentially is only going to be lasting for a few seconds. And in other circumstances, we might be doing a procedure, so such as manipulating a fracture and then placing it into a plaster and setting it into a good position, or maybe putting in a chest drain, in which cases we'll need a lot longer period of sedation, and we need to consider which agent is going to be able to give us that period of sedation that is appropriate. The other things we're going to consider are the depth of sedation that's required. Now, depth to a great extent is dose dependent with a lot of agents. But with ketamine, for example, you'll be looking at a dissociative sedation. Now, there are pros and cons to that dissociation, and you really need to consider whether or not that dissociation is required and whether or not the pros and cons of that agent are then appropriate for that patient. Now, there are certain specific characteristics of the agents as well, and in a few minutes we're going to be going through each of these agents. But again, are they matched to the procedure? So, considering again things like hemodynamic stability that agent might offer, whether or not it's going to preserve the respiratory function that the patient has, or whether or not it's going to affect that and decrease their respiratory function. Some agents help facilitate muscle relaxation, so with things like dislocations or manipulating fractures, having those muscles nice and relaxed really helps you then manipulate that fracture or that dislocation into a position with greater ease. So perhaps looking for agents in those circumstances that help facilitate muscle relaxation is a great thing to do. And some agents have greater properties when it comes to amnesia. So helping that patient not remember that procedure may be really, really important, or actually in some circumstances just helping them relax a little bit more, and whether or not they truly need to not remember that procedure is important to think about as well. As we've mentioned before, when you ask somebody who's done a number of different sedations which agent that you should use for a particular situation, you will, as we say, get a number of different responses depending on who you ask. And that will be due in no small part to the clinician familiarity with that agent. And it shouldn't be underestimated that being familiar with a drug and how patients respond to it is actually really important and will, to some extent, dictate the choice of sedative agent. Now, that's not to say that it's appropriate to choose completely the wrong agent for the clinical circumstance, but you should really consider when you're performing a sedation how familiar you are with that agent and how safe, therefore, you can be by applying that experience to the patient in front of you. Being familiar with the dose that you're titrating of that sedative agent, the time it takes to see the effects of the sedation is a huge benefit when trying to ensure that the patients receive the right amount of sedation but not too much. And this really helps to ensure that the procedure goes smoothly and you don't experience complications that are associated with over-sedation. So essentially, no one sedative strategy is better than another, but trying to tailor your practice to the patient is the goal that we should all be trying to aim for. So we mentioned earlier on that sedation involves the following. So analgesia, sedation, amnesia, and on a lot of occasions, some anxiolysis as well. Now, ketamine is the only agent that can provide all of these features. And for that reason, opioids are often co-administered with the sedative agents that don't provide analgesia, and it's important to consider how we might do this effectively. Now, by giving the opioid first and giving it a chance to reach its maximal effect is a really wise strategy when it comes to trying to ensure that the sedative agent can actually be titrated accurately. Because if you give your opioid and the sedative at the same time, and they've got a different speed of onset and a different duration of effect, then actually you can be stuck in a bit of an awkward situation of trying to reach this perfect level of sedation at the right time. And we've also got to remember that with a lot of these procedures, the patients are going to be in this state where they require analgesia already. So for example, with something like a dislocated shoulder, or with somebody that's got a chest injury and you're looking to achieve sedation to then go on and perform the procedure, there's a huge benefit in analgesing that patient before you get to the point of doing the sedation anyway. So picking the right opioid if you need one and using it prior to the sedation is a really good thing to do. Lastly, just before we go on to the agents themselves, we should just think about the route by which you're going to give these sedative agents. Now, different practices will exist throughout the globe and throughout the UK, and that will be related to specific patient factors and challenges with not only the patient but also the environment. But in general, with adults, sedation should be given via the IV route, so intravenous, even though with some agents, IM, intramuscular administration, is possible. IV administration allows greater control of the procedure and ensures that access is present if you then need to go on and deal with any complications that require IV administration of either things like fluids or other medications that can help to stabilise the patient if there are those complications. So that's not to say that in all circumstances sedation has to be given IV, but there are certainly some very significant advantages to making sure that IV access is present and that that's the route by which the sedative is actually administered. Okay, well, we've probably considered enough about thinking about those patient factors and environmental factors and what we're trying to achieve here. So let's have a think now about the most commonly used sedatives, certainly in the UK, and then those opioids that may also be given to those patients. So we're going to be looking at those common agents, so propofol, midazolam, and ketamine. And then we'll have a little think about those opioids, so morphine and fentanyl. There is a fantastic document from the Royal College of Emergency Medicine covering all of the specifics about these agents, and we've linked to that in the web notes. So don't worry about remembering all of the numbers that we're going to run through here. Just want you to really try and get a feel for how those sedatives might feel to use and the sort of effects, both from a beneficial perspective and also from a complication perspective, that you might anticipate and expect when you're using them. Okay, so first up, let's have a little think about propofol. So perhaps this is more historically been thought about as an induction agent for anaesthesia, and it certainly used to be thought that this wasn't something that emergency medicine physicians or other specialists were going to be using if they weren't anaesthetists. But over recent years, it's come in to be used more and more by sedationists due to the properties which are really well suited to a lot of procedural sedations. Now, propofol is both a sedative and an amnesic, but it isn't considered to have any analgesic properties and therefore is commonly given after an opioid has been given to the patient, as we've mentioned earlier, to ensure that they've got good analgesia, especially for the presentation which may be causing ongoing pain before you get round to sedating them. And it basically gives you a patient that is really relaxed, in a pleasant state, and is reported to be quite a pleasurable drug to be sedated with. Now, it comes in a distinctive milky solution. It's administered through the IV route and it works quickly, so you'll normally see a response within 30 to 60 seconds. And its peak not being far after that, so just after 1 to 2 minutes. And that's obviously going to be affected by the hemodynamic state of the patient. So if they've got a slow circulatory time, then it's going to take longer to actually work. But it is something that you give and you see a very rapid effect from it. So this is really good for quick procedures where you want a really quick on and off effect, and it does give you some of that skeletal muscle relaxation. So again, it's really useful for conditions where the muscular tone is working against what you're trying to achieve, and again, I use the example of a shoulder dislocation for that. Now, as great as it sounds, there are some things that you need to be aware of with propofol. So it causes respiratory depression along with vasodilation and is negatively inotropic. So therefore, it can give you quite dramatic hypotension when it's used in high doses. So using it liberally in those patients, for example, that are requiring a DC cardioversion, you can get into some tricky situations. And also those patients that haven't got a fantastic respiratory drive, you've got to be aware that this could depress it even further. So just think about those things. Have they got quite a fragile hemodynamic physiology before you're starting? And are they somebody that you really don't want to cause any respiratory depression with? As we keep mentioning, titrating medications to the patient is really important. And with propofol, the standard initial adult dose is going to be 0.5 to 1 milligram per kilogram for your patient. So 40 to 80 milligrams for your standard adult is the sort of dose that you're going to be thinking about for your patient. Now, elderly patients, and there's a bit of a theme here with elderly patients, normally require much less than this. So around the 10 to 20 milligrams of propofol to be given as a sedative agent as a first dose with that elderly patient. And I'm sure there are many of us, myself included, that have been really surprised by the effect that propofol can have on our elderly patients. And you end up giving a much, much lower dose that you might anticipate and gaining a really satisfactory sedative state. One of the beauties of propofol, and I'll try not to make it too obvious what an advocate I am of this as a sedative agent, is that it's that rapid onset and offset time. So sometimes, even in the non-elderly patient, trialling a 10 to 20 milligrams initial dose can give you a feel for how that patient is going to respond to it, and then really allows some accurate titration upwards to a safe level of sedation. And as I say, personally, it's a huge favourite agent of mine because it really does allow you to titrate for that reason. Now, further doses can then be given at approximately half the amount of the initial dose if the sedation needs to go on for longer. And approximately, you're going to be looking at giving these top-ups at every 5 or so minutes. Now, these patients, as we said, tend to wake up pretty quickly, and that allows, as we said, for real control of the situation. So in summary, propofol, we've got to be aware of the fact that it can have quite significant effects, especially in large doses, on hemodynamics and respiratory drive, but it's got that beauty of being really easily titratable. You can use it for relatively short periods of time and get your patient back in the room, awake and interacting with you again pretty quickly. So next up then, let's have a little think about midazolam. So this is probably one of the agents that is most traditionally considered when you think about sedation. Now, again, in a similar way to propofol, it provides sedation and amnesia, but doesn't give you that analgesia. But as a trade-off for that, it is really fantastic when it comes to anxiolysis. So it can really help relax that patient that is in a highly anxious state, either for the presentation that they've got or with regards to the thought of going on to be sedated. It does, again, like propofol, help facilitate some muscle relaxation, and it helps put a patient, again, in a really nice state. Now, there are some differences when comparing it to propofol, as you might expect, and probably the most notable one is that it takes a bit longer to work with comparison to propofol. Not a massive amount longer, but the initial onset time is about 1 to 2 minutes, and the effect peaks around 3 to 4 minutes. What that does mean is that titration of it is slightly more challenging in that you're going to need to be a bit more patient and you won't see that effect straight in front of you. So you need to give them a bit more time to make sure that you're not going to go in with your initial dose and then come in with those extra increments. It's going to take around 3 to 4 minutes for you then to get that peak effect. And then it goes on to last for a longer period of time than propofol, so around that 30-minute mark. Again, you need to be aware it can induce some hypotension, but probably less significantly than you'll see with propofol. And again, when we're looking at giving midazolam, especially in those higher doses, it can induce some hypoventilation. Now, it's administered again in an intravenous route at about 1 to 2 milligrams initially, over 1 to 2 minutes, and then with top-up doses of 0.5 milligrams as required after 2 to 5 minutes. Again, in the elderly, similarly to propofol, you're going to give a lower dose because they're going to be more sensitive to it. And that's trimmed back then to a dose of around 0.5 milligrams for the initial dose. So when you're comparing these two agents, propofol and midazolam, you can pretty much consider them as getting similar effects. So it puts the patient into a really nice, pleasant state of relaxation and sedation, and is normally used in combination with an opioid to achieve the analgesia that you'll want for your patient in most circumstances. They can, as we've said, both slow down the patient's breathing, and they can both lower the blood pressure. And therefore, as you would expect, a really considered and titrated approach to using both of these agents is the way to go. And the reason for talking about them together is because the third agent that we're going to discuss, ketamine, really does work in a different way and does give you a patient that's sedated in quite a different manner. So with ketamine, you'll be looking to achieve a dissociative state of sedation. And probably the best way to describe this is like when you're working with James and Rob. So in other words, the lights are on, but nobody is really home. You speak to them, they don't respond, but they might occasionally seem to react to what's going on. But essentially, they haven't got a clue and they aren't being affected by what you're doing. They look a little bit like a zombie. Ketamine can also be used in subdissociative doses as an analgesic, but this isn't what we're trying to achieve here. We're going for sedation. And not only do they stop responding to you when you're talking to them, but what you'll normally note is that their eyes become glazed and you'll probably start to see some nystagmus, so flickering of the eyes, and that's an indication that actually your sedative level has been achieved. With ketamine, again, you're getting the whole deal, and that's a reason that a lot of people like using ketamine. So you get the full range of what you're trying to achieve with sedation, including analgesia, all in one agent. So that's a huge benefit in some circumstances. Now, ketamine, again, if we're looking at the good things about it, tends to preserve the cardiorespiratory status and therefore doesn't give you as much concern with regards to the risk of apnea, or at least depressing respiratory function, or of that hypotension, which can obviously be of concerns in certain presentations. So it's sounding pretty good, isn't it? So surely we should be going for ketamine with all of our sedations. Well, that being said, there are some other things that we need to be aware of that ketamine can affect. So in converse to that sort of parasympathetic, relaxed state that we're looking at with midazolam and propofol, Essentially, with ketamine, what you're looking at here is a sympathetic response. So what you're going to get is possibly some tachycardia and some hypertension. And it can also lead, in a number of patients, to hypersalivation, so they can start to get more secretions than they might have had before you started that sedation. And in a certain number of patients, also laryngospasm, which, although is really rare, can be a potentially really stressful thing to deal with. So you need to be aware of the fact that laryngospasm is a potential. And as all of us know who've done enough ketamine sedations, you can get an emergence phenomena. Now, an emergence phenomena is when a patient gets distressed and agitated when they come out of their sedation. And that can be a really difficult thing to deal with. So the best thing is to try and prevent it in the first place. To do this, we should really try and create a calm and relaxed environment. And certainly in the pre-hospital setting, that does have its challenges, but we can all try and make the scene as relaxed and as calm as it possibly can be. But also clinicians will at times give midazolam to try and achieve the anxiolysis, just in small doses, just to try and, again, mitigate against this risk of an emergence phenomenon. Now, the frequency to which you actually will see this emergence phenomenon is variable depending on the definition of emergence phenomena you use, but this isn't a rare thing to see. When we talk about routes, ketamine can be given by a number of different routes, which include the intramuscular route, which can be helpful again in certain circumstances. But for the purposes of this section, we'll be talking about its use in an IV administration. So you'll be giving around about 1 milligram per kilogram in your fit and healthy adult, down to around 20 milligrams in your elderly patient of average size. Now that's given over about a minute period, with around a quarter to the half of the same dose required every 5 to 10 minutes if you need to then prolong that sedation. It's not a massive amount of time that you'll be waiting to see its effect, so again, that will take around about a minute, and its peak effect will be around the 2-minute mark. But what you need to be aware of is that this is going to last a lot longer than propofol with its sedative effects, probably around the same sort of duration that you'll see with midazolam, so for around that half-hour mark. So giving you a lot longer sedation, which may fit the clinical circumstance that you want when you're performing your procedural sedation, but may also not be what you're looking for. So you might get, if it's a relatively short procedure, a patient that's sedated for a lot longer than the duration that you necessarily need. And in that way, it probably makes its titration, when compared to that quick on and off effect of propofol, a little bit more tricky. So those are the three main sedation agents that we're going to mention. So propofol and midazolam, they're pretty similar. They give you that relaxed state. And then ketamine, which gives you that dissociative state, each of which have got pros and cons to their use. Now, we did mention that with both propofol and midazolam, they don't hold any analgesic properties. So traditionally, they are combined with an opioid. So the two options that are probably seen most commonly are going to be morphine or fentanyl, again, which have both got their pros and cons. But the main difference is, I guess, is that fentanyl has a more rapid onset and a shorter duration of effect. Now, fentanyl, given IV, again, is 1 to 2 micrograms per kilogram, and it's going to start working again within that 1 to 2 minutes, and with a peak effect of 2 to 5 minutes, lasting up to around about that half an hour. We're probably all going to be more familiar with the use of morphine from our non-sedating practice, and morphine, IV, as we all know, is going to be given at around 0.1 to 0.2 milligrams per kilogram, with a much longer duration to its peak effect, which is going to be around 10 to 15 minutes and last around 2 to 4 hours. As always, side effects of opioids can include hypotension and respiratory depression, especially as we titrate those doses higher. So again, we just need to consider that, especially if we're then going to go on to use a sedative agent such as propofol and midazolam, which is going to have similar side effects to it. So you just need to consider that before you determine the strategy that you're going for with the patient in front of you. Okay, well, that's probably enough about those agents for now until we come on to the case-based discussions that we're going to cover later on. So it's a fair bit to take in, and as we said, go and have a look at that RChem document that we've got linked to on the website for those doses as a recap for how much you'll be expecting to give, the side effects that are associated with them, and their peak and full period of duration. There's no such thing as the perfect agent when it comes to a sedative, but certain patient and procedural factors may lend themselves slightly better to one option compared to another. As you say, you'll probably ask 10 different people, get 10 different answers for different circumstances of procedural sedation. And that's fine because it will be related to those different patient factors that we're considering, the different pros and cons of each agent, and, as we've said, the different confidence and experience that people will have accrued through use of different agents.
All right, well done, Langers. Well, that's, as always, a really useful overview for us all there. But there are some specifics that I want to ask you, mate. So I'm going to fire some questions your way, and I want to keep you on your toes. Does that sound all right?
It depends what the questions are, I guess.
So let me be the judge of whether they're okay. So I want to ask you a few specifics, though, about this. So what about flumazenil for the reversal of benzodiazepines?
So I presume when you're asking this, Rob, you're talking about your practice and giving far too many benzodiazepines and over-sedating patients.
No, I just think it's good to have an awareness of some of the antidotes that could correct some of the issues associated with procedural sedation, Simon. So yes, do speak further about flumazenil.
Okay, fine. So flumazenil is a reversal agent for benzodiazepines, and I guess certainly, and again, reflecting probably my age and my era of growing up, it used to be one of those things that we used to draw up or at least have to hand when we were administering benzodiazepines in case we overcooked it. And I guess what a benzodiazepine over sedation is going to look like, as we've alluded to, is somebody that's going to get some respiratory depression. And I guess specifically after the procedure has actually finished. So they're going to be quite flat once that painful stimulus has been removed. Let's say maybe we've been manipulating that fracture and then that stimulus is suddenly taken away. And actually they can have quite a reduced respiratory rate and quite poor tidal volumes. Now, I guess being aware of the fact that we can use flumazenil is a useful thing to do. But I guess the real art, isn't it, is just trying to anticipate the fact that you're going to be removing this painful stimulus. So this patient is going to become more sedated once the procedure has finished, if they've still got a decent amount of benzos on board. And actually, it will be very rare that you're going to get into that position that you're going to need to consider giving flumazenil, because appropriate airway maneuvers, like we're going to talk about, appropriate patient positioning, engaging with that patient and talking to them, and if required, positioning that patient with a bit of a jaw thrust, perhaps providing a couple of breaths and supporting their ventilation is a perfectly fine thing to do. Now, you might think, why would you do that? And why wouldn't you just give flumazenil? Well, in giving flumazenil, I guess that means in some patients that present that might take a few benzodiazepines, might then sit in more of a pro-seizure type state. And if you've used flumazenil to reverse the benzodiazepines, then there's a risk that you then can't use further benzodiazepines to sort out a seizure. So that's a bit of a circular explanation, but does that make some sense at least as to why I think flumazenil isn't something that we should just be giving, and certainly isn't something that I'm going to have drawn up ready there at the patient when I'm giving some midazolam?
Yeah, no, that makes perfect sense to me. And actually, in practice, I can't honestly remember the last time I used flumazenil. But going back 10 years ago, like you say, you would have this drawn up every single time for every single procedural sedation, really. So it's much less rare to see it in practice now. And I think that's just a reflection on potentially that we might have become a little bit more competent and a little bit more used to using benzodiazepines in the correct dosing. And like you say, being aware of those, the post-procedural complications, such as the patient who you've removed that painful stimuli in. But yeah, it's a useful thing to have awareness of and to have potentially with you if you think that might be required. That's where I'd stick with personally.
I think the other thing that comes with a bit more experience and practice in this area is that patients don't have the recollection that you're expecting them to have either. And I think that plane of sedation that we're aiming for, I think with time and with confidence, actually, we probably end up aiming for a slightly lighter plane of sedation as you gain that confidence and you realise that patients aren't suffering, certainly with recollection of the events, and aren't really suffering during the procedure as well. So I think, again, aiming for that slightly lighter plane of sedation as well means that these complications and the need for flumazenil, as we used to think, probably isn't quite there.
Interesting. And that actually leads on quite nicely to our next question. So clearly we talk about orthopedic procedures quite a lot, and essentially all of these, by the very indication of them, are going to be unpleasant or painful procedures, aren't they? So do you always give opioids, for example, if you are using propofol? So do you always give opioids to your patient given that it's going to be a painful or unpleasant procedure?
Well, I was always taught to never tick true when a question came up that said always or never. So I guess the answer to that is no, I don't. And this, again, is about picking the right agent and really assessing sort of that risk and benefit to the way that you're proceeding. So, I can certainly think of occasions where you've got somebody who's really unstable with their tachyarrhythmia, and propofol being an agent that is a good, quick on and off agent, and you want to get them back to a level of stability. Now, as we've discussed, adding in an opioid brings in some other complications as well, doesn't it? So it brings in the fact that we could be looking at a bit of respiratory depression. We might be a bit more likely to get some hypotension. So I think there are circumstances within which I wouldn't always give an opioid, and I think that is just weighing up the pros and the cons of what you're trying to achieve, the urgency that you're trying to achieve it, and the risks of going for that full level of sedation and analgesia.
Yeah, I think that's a fair point. And I also think that, there is a place for giving opioids post-procedure, isn't there, if there are ongoing analgesia requirements. But, in those patients that you want to get that procedure done, it's potentially something that might muddy the water a touch. So, yeah, choose the right patient, I guess, would be a good thing with that. Would that be fair to say?
Yeah, I mean, I hope my patients that have had a DC cardioversion don't go on to get ongoing pain, because I'm certainly thinking
that's a bad day right there.
Anticipating that was something that was going to happen.
Band-like right across the chest. All right, yeah, so that leads nicely on to my next question. So you read a lot about this on FOAMed. What about ketofol?
Okay, so ketofol is a combination, isn't it, of ketamine and propofol. And when we've been through sort of the pros and cons of these agents, we talked about propofol, giving you that really relaxed, and how we might think of a parasympathetic type state. So someone that's really chilled out. And then we spoke about ketamine giving you that sort of dissociative type state, but also having that sort of increased sympathetic drive and having that tachycardia and preserving that respiratory function. So it would seem, wouldn't it, in theory, that actually combining these two agents might be able to really smooth off that chance of getting cardiovascular instability whilst maintaining that nice respiratory drive, but also giving you a bit of that muscle relaxation and that chilled out state, and perhaps less of an emergence chance that you might get with the ketamine. Well, certainly this is something that I went through a phase of sedating patients with. And again, this comes back, doesn't it, to that familiarity with the drugs that you're using. And it does seem like a really nice combination because, again, it gives you that analgesia without having to add in opioids as well. So it's a complete sedation package given in one. I think it's fair to say that the evidence out there is equivocal on the use of ketofol, and it seems pretty safe. It doesn't seem, from the evidence that's out there, like it's got any phenomenally advantageous effects. And I guess the use of it is what I'm trying to say. It is completely justifiable, but I don't think it's absolutely mandatory. And I think it's one of those things that's really nice to get some experience in using. I would anticipate that I will continue to use it from time to time as the situation is appropriate, but it certainly hasn't replaced the other options of using ketamine or using propofol with some opioids for other situations as well.
Awesome. Okay, thanks for that, man. So last question, I promise. I will leave you there. So, and this is coming back to the whole idea of ketamine and the emergence phenomenon that you might get. So do you give a pre-med of benzodiazepine, or do you give some midazolam prior to giving ketamine in the hope of preventing that emergence phenomenon?
God, this is a tiny bit similar to appearance in coroner's court, the way that this questioning's going, but I think
well, if you want to get it off your chest, mate, you carry on. Yeah.
So in answer to that, no, I don't. And I know there are people that will always give midazolam for their ketamine sedations, and again, the evidence out there, I think it depends which way you want to read it and which way you want to appraise the literature, but There are certainly those patients, aren't there, who are in an agitated state before you go to give the ketamine, who would benefit from some anxiolysis preceding, the actual sedation that you're going to achieve. And anecdotally, again, I think those patients who are in that hyper alert state are probably the ones that are going to be more likely at having a severe reaction to their ketamine, and you're going to get this emergence phenomenon. So I think in those patients, they're a great example of where I'd be keen to give some midazolam prior to that. But I guess I've also got a tendency that I would try and limit the number of medications that I give to a patient, just to try and, keep things as simple as possible, as often as possible. So, midazolam for me has definitely got a place in the right patient. And whilst it would be totally appropriate to give that for your patients before you're sedating them, I don't think there's an absolute mandate to need to give it to all of the patients.
All right, awesome. I guess it could also be useful for a bit of anxiolysis for the sedation team in the agitated patient, but we'll leave that there. Jokes.